you have a selection criteria, it's less than 1%, and bowel problems in 4%. These patients are the late complications over years, and this is very realistic and very honest figures, at least in our hands. Next, please. What about the learning curve? Honestly, I tell you, if you are 3 years resident and make an active assistance one senior urologist who is expert in this diversion techniques, you assist him in 10 cases and be assisted in another 7 cases and observe it from distance. I will sit in a chair and let him, the trainee who is under training will stay for 8 cases, and I observe him only from distance. I will stay in the coffee room close to him, and then every half an hour come to see what is he doing it exactly, to give him partially the confidence to do it alone. And then he will be independent surgeon, expert surgeon after these 25 cases. But important to do it consequently, not over 3 or 5 years. So he has to do it twice a week. Usually you have to go to a busy center and they have an active hand on that. And after these 25 cases, you will feel that you are mastering the technique. In our busy center, we have to do that in these 3 months. So if you can come as a fellowship with a 3 months duration, as your age at 3 years urology, you will be a very senior surgeon in the task of diversion techniques, of course. And I mean what I say exactly. Next, please. What about when 15 years follow-up? This number has increased because we recruit more patients, but this slide only allocated on 180 patients. The minimum one of these patients passed 15 years after orthotopic new bladder because they were young at the time of the surgery. Continence at daytime 88%, at night time 70%. The residual urine more than 150 ml is 8%. The need for CIC 6%, and in these male patients. Urethral stricture at the anastomosis 7% over years. Urethroileal anastomosis only 2%. Renal function deterioration 3%, pouch stones 8%, and overall quality of life, they are very well satisfied with their life in 82% as estimated by the healthcare questionnaire system. Next, please. What about the use of the alkali therapy? Is it important for every patient who is diversion technique? In our patients, carefully 30% of patients may still need it because of marginal kidney function, of course. But 50% of the patients, after a long time follow-up, they stopped it at 1 year with no harm at all, provided that they have a good kidney function. And the remaining 20% are not regular to use it, sometimes use it, sometimes not. But anyway, in the first 3 years of follow-up, we advise them to stick the alkali therapy whenever it is possible. But many patients, they feel that it is nothing for them and they stop by their own. We collected all these patients who stopped it by their own, and then we take a blood sample and ABGs and all these urine tests, and it showed to us that there is no harm from omitting this use of alkali. So it is not a must in every patient. At least now we need that 30 patients of the overall number may need it because of marginal kidney function, but 70% may not need it with longitudinal follow-up. Next, please. Next, Ahmed. When you do a urine test after many years of diversion, what it showed to you? The urine in the pouches is not a true urine. Now, don't rely on the urine stored in the pouch as it is urine coming from the kidneys. No, it is stored in the pouch, and this pouch is intestine, and this intestine is absorbing and secreting. So the urine composition has been changed a lot. We'll find some bacteria, usually it is harmless bacteria. If you would make a urine culture, you will find that positive bacterial culture with E. coli or Klebsiella or whatever, but the patient has no symptoms at all. In this condition, don't give him antibiotics. If there is no symptoms, especially if there is bacteria who is asymptomatic, don't give him any antibiotics. If it is symptomatic, it's usually less than 10% of patients. Symptomatic means discomfort, urine incontinence, frequency, and sometimes suprapubic pain. We call it pouchitis symptoms. In this condition, you can give an antibiotic, of course. No treatment of if no symptoms, and keep an eye on the residual urine. And the significant PVR, post-voiding residual, is not like the normal bladder, as when the cutoff limit is 100 mil. No, here is 150 mil. Usually, it is not significant residual urine if you have capacity of the reservoir more than 500 milli capacity. Next, please. Then we come to what we did in the ileal conduit. Of course, it is a second alternative indicated in 40% of patients. Of course, there is a very important technical consideration. Maybe in another webinar, we can have the whole lecture around how I do the ileal conduit, because many hands are doing it in different techniques. Everyone is thinking that he is the best one to do ileal conduit, and I feel that we have to see each other doing it, and we have to show the results, because I feel that everyone has his own technique. I implant the ureter first or fix the stoma first. What's the length of the bowel used? And the Wallace 1 or Wallace 2 or Wallace 3, of course, and the incidence of reflux and incidence of infection, incidence of that, stenting or no stenting, all these issues also is quite important topics to discuss. Of course, the length of the segment ranged around from 12 to 20 centimeters according to the thickness of the abdominal wall. And nisbet individual, I like to implant the ureters individually. The left ureter come end to end, which is very anatomical, passing behind the colon to the end of the ileum. And the other one on the right side will get into the side, of course. But I fix the stoma to the skin. Maybe next time I show you the video how we do such a technique. I fix usually stents up to from 7 to 10 days. And of course, the results are quite satisfactory of that. Next, please. You have to take your time and your effort of selection of the stoma. Maybe the patient will forget everything about his disease except the abnormal side of the stoma. The stoma, when it comes in abnormal site, like in a crease or in a folding in the abdominal wall, it would be disaster day and night, and nightmare for the patient when he has leakage and not fitting stoma appliance in that. So you have to have stoma marcation before the operation, not only in the supine position, but in sitting and standing and different positions. Of course, you have to select the most proper bulging area in the abdominal wall, and take your time in having a suitable place, otherwise you go in trouble with your patient. Next, please. Of course, there is a lot of minimal invasive techniques, and some adopted have a radical cystectomy and diversion using a robot, assuming that they don't have a scar. And I don't believe that. The scar is not the issue at all. And what you do if you leave behind 75% of patients who underwent radical cystectomy by robotic approach will receive ileal conduit, but no scar, but there is no very bad, ugly stoma, of course. And this is the expense of the orthotopic new bladder. But in this lady, I offered her orthotopic new bladder. She was not happy with the scar. I said, okay, take a gift from me. This is a nice tattoo. Fix it to your abdominal wall, and it looks to me very attractive, of course, and your husband will be also very happy with that. And I did an orthotopic new bladder in the lady. I hide the scar. If the scar is a headache for those who are advertising for minimal invasive techniques or robotic. I don't hate the robot, but I don't like it in the cystectomy. But I am very fond of it in other partial nephrectomies and radical prostatectomies and all the techniques. But maybe cystectomy, it needs a little bit more time. Next, please. Technical consideration, of course, fixation of the loop, and I think maybe next time we can have a much wider room in discussing the technique of ilial loop, how we do it, and how the stomach care is, and etc. Next, please. This is a list of complication of ilial conduit. It is not absolutely safe technique. Sometimes we have a black stoma the second postoperative day. Sometimes we have a prolapse. Sometimes we have a parastomal hernia. Sometimes we have a psychological upset in 60% of patients from he is away from social life. He cannot go to a swimming pool. He cannot gather any individual meetings or be a social cooperation with the family. Usually he has some sort to hide. The bag is fixed to his abdominal wall with full of urine. And especially in our area, which is a temperate area, maybe the hotness during summertime makes sweating of the skin, and all these appliances will fall down. Of course, it will be a very big problem for that. Next, please.
بعد إذنك يا باشا, before we go next, can you tell us how, as we in Germany do a lot of ilial conduit, unfortunately, in few ilial new bladder, how do you deal with the black stoma post-operatively? Can you tell the participant, please? Can you go back?
Yes, yeah, it is. Can you have the yes? If your residents clever enough, he has to report to you at the evening of the operation about the color of the stoma, of course. If it is a bright red and vascularized stoma, or getting worse and black. Sometimes dusk stoma is not ischemic, but a little bit congestion. So what you do is to scratch it by a tip of a needle. And if it bleeds, of course, this is just a congestion. If it didn't bleed but gets black and with time, so you have to immediately go by do endoscopy. Even in the theater or even in the recovery room without anesthesia, bring the cystoscope and go in the lumen of the stoma. If you feel that the dusk color only affecting the distal inch, of course, this may be the skin area. So you can just declose the area and pull it up and then revise the stoma, as you can see the picture, the upper picture on the left-hand side. The discoloration was only limited on the distal 1 inch and has been revised even with local anesthesia. But if you feel by loboscopy that the whole thing is black by the cystoscope of this conduit, so take the patient again, because there was a major insult of the blood supply of the feeders of the ischemia of this loop, and you may revise the whole operation. In one time, when I was in Germany, the whole intestine has been turned up, and it went into ischemic. Part of this was also the window of the iliac conduit, and we have to re-explore the patient very early in the recovery room and correct all things. Again, your residents should be clever enough to report you not only the urine output, but the general condition of the patient, or the drains bring bleeding or not. And if he didn't tell you about the condition of the stoma, teach him. If he missed it, again, hurt him and prevent him from assisting you for a couple of cases as a sort of punishment, because he has to have a very careful eyes about this, because if we stay for the whole night and the loop gets into gangrene, it may be a big problem for that. Next, please. Continent cutaneous pouches, of course, it is the least indication for that, but still we do it when required. We have to create Mitrofanov or appendix stoma or serous line outlet or whatever, but we need in this condition to have more lengthy segment of the bowel. and you can use appendix or tapered ileum using Monte technique. And usually we have 470 cases of serous line outlet, especially on the children group, and now 247 patients, including 160 children. But the technique is a little bit tedious and needs to be patient and takes a longer time. Of course, it is not the